everyone, and welcome to the 90th session of e-NISCHIT, the national initiative to strengthen collaboration between HIV/TB through e-learning. I would also like to introduce my team here. On my left, I have Dr. Anuradha. She is the technical coordinator from Share India, and she does all the technical work behind this session. Then we have Rakesh from Share India, who is behind the camera, and he is the IT coordinator. And from Echo India, whose module we use for this particularly, these Echo clinics, is Ankur, and he's also behind the camera, and I'm Dr. Upasna. And while we launch the attendance poll, I would like to take this opportunity to introduce our expert for the day. Today, our expert is Dr. Aditya Nath Aggarwal. He is a director, professor, and head of Department of Orthopaedics at the University College of Medical Sciences. Just for the information, this is one of the major medical colleges, a very high burden medical college of Delhi. It falls in the eastern part of Delhi, and it has a very, very heavy footfall, not only because of the overpopulation that we see in East Delhi, but also because lots of people coming from the neighboring states. So actually our colleagues who work in this university hospital have lots and lots of practical experience, and we are indeed fortunate that today for our case, we were able to get the HOD of orthopedics from GTB, that is the university hospital. Welcome, sir, to the platform. We are indeed happy to have you. Today, the case will be presented by our staff nurse from the old General Government Hospital, Vijayawada, Mrs. Deepthi.
This is a case of ART number 11274, age 52 years, gender female, weight 80 kgs. Reason of case presentation was spine. Duration of treatment, complication during the treatment and post-treatment changes or recurrency. Date of ART registration 17/2/2009. Date of ART initiation 23/8/2012. Date of TB confirmation 28/1/2022. Date of ATT initiation 28/1/2022. Type of TB detected, extrapulmonary case, clinically diagnosed. Past history of the TB nil. Date of IPT completion 12/12/2020. Other details. Patient registered in February 2009 with CD4 count of 516 cells and initiated on ATT with Zedalan on 23/8/2012. Patient bilirubin levels raised to 1.9 mg/dl within 1 month of initiation and was stopped ART with diagnosis of nephropin-induced hepatotoxicity. Reinitiated ART with Zedalan on 31/10/2012 and continued on same regimen till 3/3/2017. Patient was LFU for 6 months in the year of 2017 and retired back into the program and initiated with the TLA on 11/9/2017. As her HB was 46% and continued with TLA till 2/11/2020, where the patient was substituted to TLE due to no stock of TLE and continued till date on TLE. Patient was infected with COVID in June 2020 and had been recovered. She developed low backache in October 2021 after 1 year of the post-COVID infection, where she was consulted with ortho privately and was treated conservatively with pain killers and advised weight loss as she weighted 90 kgs. But she was not attending the ART center. She had soon used to come and pick up pills. Even after using the painkillers, there was no relief and consulted back with same ortho and was advised to X-ray LS spine, where she has been diagnosed with spondylitis and started treatment. 1 month later, she consulted rheumatologist privately and was advised to continue same treatment given by orthopedician and advised to physiotherapy additionally. Unfortunately, the pain was worse after physiotherapy and consulted a neurologist privately and was diagnosed with port spine based on MRI spine in January 2022. She was hospitalized privately and started on ATT 28/1/2022 and linked back to NTEP TB unit, Ujuru, and continued ATT till 23/3/2022 and linked to New GH ART Center in March 2022, where additionally DTG was based given. Patient is known case of diabetes mellitus 2 and the patient past 4 years and medication and also known case of the hypothyroidism and on medication of 6 years. Now the patient complaining of pain radiating to right side of thigh and persisting low back pain and into her CP phase 1 and was using the CPT steroids. CD4 count ART initiation 206/23/2012. Last 3 serials CD4 count CD4 1 441 23/3/2018, CD4 2 243 14/9/2021, CD4 3 177/33/2022 privately. The laboratory reports viral load if available. Viral load 1 4,23,042 14/4/2021. Viral load 2 TND 14/9/2021. CD4 127 33. Viral load 3 39 copies less than 322. Laboratory reports dates 26/1/2021. Serum creatine 0.8 mg. Electrolytes sodium 137 micromoles and potassium 4.5, 4.8, RBS 99 mg, HB 9.4. Other relative test, thyroid test T3 1.12 to T4 8.7. HPC 1C 9.8, TSH 4.56, HBS is NR, HCV NR. CB not XJ LS spine AP 29/2021 distal lumbar spondylitis changes. XJ previous review view 26/1/2021 22 blunting of left CP angle pleural effusion mild hazening involving the both lungs and spontaneous edema. MRI left spine 21/1/2022 diffuse the marrow edema of D12 and L1 vertebral bodies, small epidural collection noted at L1 vertebral body causing the compression of pons medullaris D12 and L1 disc epithelial relatively preserved sign of spots disease of D12 and L1. ART regimen TLD and DTG 50 mg, ATD regimen 3 FDC 5 pills day, CPT-S. Other medicine Prophylax 400 mg, injection Decoder 1 cc 4, gabapentin and oxcarbazepine and amitriptyline. Issue of discussion: why still presenting pain and radiating pain to thigh? Duration of treatment: how do we approach if such a case with similar complaints visit ART center? Thank you, ma'am.
Thanks a lot, Deepthi. It was an excellent case that Vijayawada ART Center has presented to us. I would summarize the case, but before that, would anybody want to ask anybody from Deepthi from the audience? Would anyone in the audience want any clarification? So if there's nobody, then I would just sort of summarize the case. The interesting thing about this case is that this case has been in the system of ART for the past 12 years. The case presentations for ART center presentations are different in this way. When you usually do a case presentation, max will have a history of 6 months, 1 year, and usually it is a 2 weeks history when the patient comes to us. But when you start talking about an HIV positive person, And the case history in an ART center, it spans 12 years. So 12 years of history, 12 years of investigations, 12 years of going away and coming back, 12 years of complaints. So it's, at times it becomes very overwhelming even for the center to decipher what has happened to the patient over the period of time. But now with this case presentation, a lot of things have become clear. This is a 52-year-old PLHIV. She's a female, and she was started and she was registered in the pre-ART registration in way back in 2009. Now 2009 is 12 years ago. That time the ART guidelines said that for asymptomatic people, you do not start ART until they are less than 500. So that time her CD4 was 516. She was kept in pre-ART care and not started on ART. In about 3.5 years, when she came back to the center, she must have kept on coming back and forth. But in 2012, that is about 3.5 years later, it was seen that her CD4 fell to 206. Now, once the CD4 fell to 206, even if the patient is asymptomatic, that time the guideline said that you have to start treatment. Now the guideline says, for everybody's reference, what does the guideline say now? Irrespective of ART center, irrespective of the CD4 count, ART is to be started. But it was not always like this. Earlier, we would only start when in an asymptomatic person when the patient had fallen to around 200. So similarly, in this case, in 2012, her CD4 was found to be 206, and she was started on ART. She was started on ZLN, which was a first-line regimen at that time in 2012, which is about 10 years ago. She had some liver dysfunction, so she was shifted to ZLE, and then this carried on till 2017. This was about a duration of 4.5 years. So 4.5 years she is on treatment. Then suddenly the patient defaults for 6 months or is lost to follow up for 6 months, in which period we expect that the patient must not have had drugs because nobody buys them or takes them from the market. For 6 months she was off any treatment. 6 months later, she is retrieved back by the center. The center did their follow-up and they sent out people, and the patient is retrieved back. And she is again put on ART in 2007. That is in September 2007. In September 2007, when she is put again on ART, her CD4 is put, that time I think the CD4 they have not given, but after putting her on ART, the CD4 after the first 6 months was very good. It was 441. So despite a gap of 6 months, I think the patient recovered in 6 months from whatever she had lost. In terms of resistance to ART, we cannot say, but clinically she definitely improved even after the default. And now the patient has been on this ART for the past 5 years. Till date, she is on TLD. But what happened in between in these 5 years after 2017? She first developed COVID in June 2020, from which she recovered. Then while she was still on ART, in April 2021, there is a viral load, which shows that her viral load was very high. Now, I do not know why this viral load should be so high. There is no CD4 for this time, but probably the reason must have been that during COVID times, there must have been some problem of missed doses during admission, during COVID, due to lockdowns, so that her viral load shot up to more than 4 lakh. So one of this event that happened in the last 5 years. However, the patient continued on TLD, as has been explained. Then another CD4 was done 6 months later, in which the CD4 is 243. So there is a beginning of falling of CD4. The last CD4 we have is 441. Then there is a period of instability in all health services. Now when we do a CD4, it is 243. But interestingly, her viral load is not detectable. So it is an indication that after this initial problem with COVID, she must have gone back on her ART. Otherwise, there is no way that the target load would have become undetectable from 4 lakh. Similarly, patient is again followed up, and after this September we do a CD4, September we do a viral load, CD4 is low, viral load is undetectable, and October she starts complaining of backache. Now this backache is so severe that she goes to an orthopedic surgeon, she gets an x-ray done, she gets physiotherapy done, she goes to a rheumatologist, things don't work for her. Finally, she goes to a neurologist, and a neurologist gets an MRI LS spine done, which is suggestive of port spine of D2 and L1, plus they also find an epidural collection, plus they also find some amount of compression of the conus medullaris. So with this MRI report, she is admitted. She is admitted around January 22. October 21, she has backache. September, she has her parameters done. Her CD4 is falling, viral load is not detectable. October 21, she gets backache. She keeps on going from one place to the other. January, she lands up with a neurologist. The neurologist gets a MRI done. The MRI is just a port spine, and she is admitted with the neurologist. This is all happening in the private sector. Now, when she's admitted with the neurologist in the private sector, she is diagnosed with port spine, and ATT is started for her on 28th of January 2022, this year, 6 months back. This ATT was initially private, then she was shifted to the program ATT, which was, she was shifted, I think 2 months she took private ATT. And then in March 22, she's shifted to the RNTCP or the NTEP ATT. And then she also reaches the ART center. So this is a sequence of events. When she is discharged, she is given RHZE plus ofloxacin by the private practitioner. One thing very heartening that I saw in this discharge ticket was that RHZE was appropriate for the weight 80 kg. The patient was 80 kg and the doctor had very appropriately given her higher doses that would be appropriate for 80 kg. This is a thumbs up for the neurologist. Excellent. But he also added oflox. He probably wanted to augment the anti-TB activity. Whether this was right or not, we are really not in a position to say with extrapulmonary TB. He also gave her paradoxin. He gave her glycomet for her diabetes. He gave her gabapentin, oxycarbamazepine, and amitriptyline possibly for the pain. And then in discharge, there is also a tapering regimen of steroids. So she receives RHZE, oflox, paradoxin, steroids for her ATT, and she also receives gabapentin, oxycarbamazepine, amitriptyline for probably her neuropathic pain, and glycomet for her diabetes. So patient is adequately and beautifully managed in the private sector. The patient then shifts to NTEP. When she shifts to the NTEP regimen, she gets 4 FDC, 4 tablets per day. That is according to her weight. And then she also shifted to her, when she shifted to her continuation phase, it became 3 tablets of 3 FDC, 4 tablets every day. Plus her TLD was modified to TLD plus an extra dose of DTG 50 milligram in the night to cover for rifampicin. Now, what do we have? Other striking features here that we have is that I would just again reiterate, in September 21, when she gets backache, CD4 is 243. In March 22, when she is just beginning treatment for TB, the CD4 is 127. So there is still a decline. Even despite 1.5 or 6 weeks of TB treatment, there is a decline in CD4. And both times the viral load is okay. Both times in September and in March 22, September 21, March 22, the viral load is fine. So there is a case to say that patient has been on ATT for 6 weeks or more, and still the CD4, instead of being stable or increasing, it is actually falling with a normal viral load. Okay, so this is a very important indication. The other thing that we have is the lack of a reliable X-ray. An X-ray that we have, it's not a film, it is just a report that says angle blunting with bilateral haziness, very fluid overload. So once you say fluid overload, this angle blunting could also be due to CHF, but in this lady, there has been no indication of hypertension or any other cardiac disease. So it is possible that this X-ray was showing some sort of infiltrates, which could have been pulmonary TB also. The other thing that is missing here is the availability of any microbiological diagnosis, which usually happens in spinal TB, because at ART centers and general centers, we are not geared to sample epidural collections or to take a biopsy, which we could send for CBNAT or any other microbiological diagnosis. Hence, an X-ray and a sputum CBNAT becomes even more important. Because if we cannot reach the extrapulmonary site, at least let us completely investigate the pulmonary site. And let us keep on doing sputums again and again, because that is the only thing we can do when our hands are tied in case of an extrapulmonary sample. The other point that I would just like to point out here was the role of IPT. Probably the patient's diabetes or coming and going out and the COVID has been a big problem these 2 years. The disruption of medical services due to COVID, because of which I think she missed out an opportunity to take INH or TPT, that is TB preventive therapy, which could possibly, it's a big possible, I'm not saying it's because of that, it's possibly have prevented TB. So with these few words, I would just revert back to Deepthi and ask her, would she want to explain something else, or does she want to add to what I have said? Deepthi, do you want to add to anything? Very well worked up case. I congratulate you. And 12 years of history is not easy to decipher. Like, it's really very difficult to decipher 12 years of history in a patient. Still worked up very well. Congratulations to you and your team. And with these few words, I would now like to request the expert for the day, Dr. Aditya Nath Aggarwal, to kindly talk on this case, to talk on spinal TB, to tell us what is the theory behind it and what more could have been done in this case, or what more can still be done in this case, so we can learn from this case for our future cases also. Over to you, sir.
Good afternoon, everybody. It's a pleasure to be around a really nicely worked up case. Now, let's go to a brief case summary where apart from the
Sir, please, can you put it in presentation mode?
I'm sorry.
Thank you, sir.
Now, a brief case summary that a 52-year-old female with a person living with HIV, she's a known case of diabetes mellitus on medication, and her HbA1c according to her notes is 9.8. Now, I'll be quickly taking the salient points which we can take forward for our discussion. There's a history of interruption of ART. She had a history of a nevirapine-induced hepatotoxicity. She has a back pain since October 2021, and she's diagnosed in January 2022. And the ATT started in January 2022 itself. So that means within a span of 4 months from the onset of her pain, she is diagnosed and started on appropriate chemotherapy. Her X-rays of the lumbosacral spine are within normal limits, and her MRI, which was done of the lumbosacral spine, was consistent with tuberculosis of the dorsolumbar spine. Now, her pain is persisting and radiating to the thigh. That's her issue. And as per the neurosurgeon's notes, there is no gross neurological deficit. That means both her lower limbs have no motor or sensory deficit, and her bowel and bladder functions are still intact. Now, from the case notes, what I could gather was that the other drugs of concern for an average orthopedic surgeon treating this case as a team would be the use of steroids, which we'll discuss subsequently. So now issues of discussion would be persistence of back pain, which are pain radiating to the thigh. Now the other issue is duration of treatment, modification of approach, if any, complications, and post-treatment chances of recurrence. Now we'll settle these things one by one. Now, coming to the pathophysiology of tuberculosis of the spine. Tuberculosis of the spine generally spreads by hematogenous route, and the primary site is the lung or the genitourinary system. It constitutes, the spine tuberculosis constitutes about 50% of all cases of tuberculosis of bone and the joint. 50% of all skeletal tuberculosis would be TB spine. And out of these 50% of the cases of bone tuberculosis, 10 to 30% cases of spinal TB. Out of this lot, up to 10 to 30% will have a neurological deficit. That means they'll have either a motor deficit or a sensory deficit, or their bowel or bladder might be involved. And tuberculosis of the thoracic spine or the dorsal spine is more prone to have neural complications. In almost 50% of the cases do you get a significant neurological deficit. The frequency of areas of involvement that we have: a cervical spine, the thoracic spine, the lumbar spine, and the sacral spine. So most commonly involved regions are the lower thoracic and the lumbar vertebra. So dorso-lumbar tuberculosis is most common among the spinal tuberculosis. After that, do you get the mid-thoracic region and then the cervical spine. So lower thoracic and lumbar vertebra are the most commonly involved. Now, coming to the types of the vertebral body involvement, the paradiscal is the commonest. That means two adjacent vertebra. I'm showing it with my cursor that two adjacent vertebra, the disc, the region around the disc space is the commonest area of involvement. More than almost 80 to 90% will have this region, two adjacent vertebra. They will be contiguously involved. Then the second less commonest would be the central type, where in the center of the body you have involvement. Third commonest would be the anterior type, where under the anterior longitudinal ligament, there's a collection which is going on. Least common would be the posterior elements, that is on the back side of the spine, which is involved. And very rarely do you have the facet joint, the synovium of the facet joints, that is isolatedly involved, which is very difficult to prove. However, with the advent of MRI, you see that more than one region may be involved. Tuberculosis is not confined to one part of the body, and it, apart from the paradiscal, you do find concomitant abscess going in the anterior part or the central part or the posterior part. And your diagnosis has actually improved as far as these regions are concerned. Now, coming to the cold abscess, the vertebral tuberculosis, or for that matter, any type of even lymph node tuberculosis, can lead to a caseous necrosis. It forms a cold abscess consisting of serum, caseous material, leukocytes, bone fragments, debrima, and latent or dead or alive bacteria. They penetrate the ligaments. And so now vertebral tuberculosis leads to a caseous necrosis. And this cold abscess penetrates the ligaments and tracks along the path of least resistance along preformed anatomical facial planes, blood vessels, and nerves. And it tracks and manifests itself an abscess away from the original bony lesion. And they don't incite any signs of inflammation. That means they are not red, they are not hot, except for swelling. There is no other sign of inflammation. Next slide, please. Now, the clinical presentation is symptoms of tuberculosis of the spine are usually insidious. That means it is not a day one happening. Gradually, the patient is made aware of his symptoms. There's a history of pain in the back at the disease site or along the course of the nerves lying adjacent to that vertebra. There may be a history of constitutional symptoms like evening rise of temperature, loss of appetite, weight loss, or malaise. However, they may be even absent. Absence of constitutional symptoms doesn't exclude the diagnosis of tuberculosis in extrapulmonary sites. The spine may be stiff and there will be pain on any movement of the spine. And there is a tenderness at the site of involvement. If you were to run your fingers on the back of the vertebra, you are likely to find tenderness, and there's likely to be some kyphotic deformity which develops in due course of time. During the sleep, the protective muscle spasm relaxes, permitting the movement between the inflamed surfaces, resulting, and that's where the patient gets up from his sleep, which is called the typical night cries. Next slide, please. Several of these signs and symptoms may be absent in early stages, even in cases of active vertebral disease involvement. Hence, a high index of clinical suspicion has to be kept about this entity, especially in endemic regions like India. A significant delay in weeks to months is common in diagnosing tuberculosis of the spine in our day-to-day setups. Neurological involvement. Now let's learn from our anatomy. The spinal cord usually ends at the upper border of the first lumbar vertebra, and it ends in the area of conus medullaris, from where you have nerve roots going along the canal, which exit from the lumbar vertebra. So in our society, a significant number of patients only come to the hospital when they have significant weakness in their limbs. Before that, they just don't come to the hospital. By that time, some advanced disease has already set in, which is a neurological deficit. Next slide, please. On examination, these patients may be walking with a cautious gait. That means they have pain, so they walk slowly. Or if they have a weakness in the lower limbs, their gait may be clumsy. If the cervical spine is involved, then both your upper limbs and lower limbs, that means all the four limbs are involved. If the thoracic spine is involved, then you have only weakness in the lower limbs, and there may be a concomitant bowel and bladder involvement also. And there's a stiffness in both the lower limbs, which is called spasticity. If there is involvement of the lumbar spine, then these patients typically don't have spasticity, or it's a lower motor neuron type of paraplegia. The earliest finding of a spinal cord involvement, even in the absence of motor deficit, is an ankle clonus or an upgoing Babinski plantar response, where the clinician detects this. Next slide, please. The laboratory investigations in an active disease is a raised ESR, which may not be present in patients living with HIV. There may be anemia and relative lymphocytosis. However, most of our patients are poor nutrition, and this may be a common finding in a normal population subset also. The Mantoux test may be a non-diagnostic in endemic areas and may be negative immune deficient states, especially in HIV states. So it may not be contributing to our diagnosis. The cultures that we obtain require 4 to 6 weeks of incubation. However, the BACTEC radiometric cultures takes less than 2 weeks. However, resources may be a big constraint. A polymerase chain reaction can differentiate between a typical and an atypical mycobacterium. That means atypical mycobacterium can be mycobacterium affecting the animals or other forms of bacteria which are not classical Mycobacterium tuberculosis. And however, even the dead bacterial DNA can be replicated in PCR, and even in Egyptian mummies, you have had PCR positives. That means dead bacteria lying in mummies and you can replicate them. So it has to be interpreted with caution. The Gene Expert is a rapid test for detection of bacilli, and it gives you rifampicin resistance also. Next slide, please. A CT guided biopsy or a X-ray guided biopsy or a FNAC is useful to obtain tissue for diagnosis of spinal lesions. However, it has to be done in centers which are used to dealing in such cases. Tissue obtained from biopsy should be subjected to a AFB staining, culture, and drug sensitivity in the same setting. It's a precious tissue. You can't keep on poking your vertebra again and again. So once you get a sample, it has to be set for all the diagnostic setups in the single go. Then you can send for drug sensitivity, polymerase chain reaction, or other molecular diagnostic tests, and a histopathological examination. Because many times it's a paucibacillary disease where the mycobacterium is very less in the bone and joint infections. So you may not be able to obtain an acid-fast bacilli. So a histopathological examination, although a lower level of evidence, is also mandatory. And they are very useful in full diagnosis. Now, what do you see on a plain X-ray? It is plain X-ray is an initial investigation. It provides information about the number of vertebrae involved, the level of bone destruction, and the angle of the deformity. The lesion of the vertebrae can only be seen on X-ray when bone loss is 30 to 40% of the calcium content, and generally it takes more than 3 months for any tangible changes to appear on an X-ray after the onset of the disease. X-rays may not be able to pick lesions which are less than 1 centimeter in their dimensions. That's a major drawback. The classical radiological findings are a regional osteoporosis. That means you see less of the calcium content, you see less of whiteness in a plain radiograph. There's a fuzziness of the adjacent disc margin. Now you see this disc margin looks good, but look at the next one. There is fuzziness. That means it is ragged. and there's a reduction of the disc space. You see this vertebral disc space height, and look at this involved vertebral disc space height. This is reduced. And there may be an anterior wedging of the vertebra. That means the height is reduced. This height of the vertebra is reduced. And there may be a kyphosis, that means a deformity of the vertebral column. And you are likely to see some pre and para soft tissue shadows on an X-ray, which I'll show you on the next X-ray. Now, if you were to appreciate this white arrows, this is the prevertebral shadow. And now look at the lateral view of the same. You see this vertebral body, you see this vertebral body, and now look at this big vertebral body. This is not a big vertebral body. In fact, these are two vertebral bodies which have collapsed and merged into one. So a cursory examination, you may say that this is one vertebral body, but look, this is one collapsed vertebral body here lying, and this is another vertebral body which has got fused with this. So this is in fact one vertebral body. So let's not miss these findings. And in a cervical spine X-ray, this is from one of my own publications. Now you see this soft tissue shadow vertebra. This is the trachea and the esophagus, black air. And now look at this area, more than one vertebral width. And this space is filled with pus granulation tissue. This is the increased prevertebral shadow, typically seen in cervical spine X-rays. Next slide, please. Next slide, please. Now, the role of MRI in TB spine. It is more sensitive and specific. It has a very high contrast resolution, and it gives you multiplanar capabilities. It gives you axial cuts, that means slices cut in the axial manner, sagittal plane, and coronal sections. It is better in diagnosis of difficult sites like craniovertebral regions, cervicodorsal regions, posterior elements, sacrum and coccyx, which are not very well appreciated on plain X-rays. Epidural extension of pus and tubercular debris is better appreciated because you can get axial cuts and sagittal and coronal cuts. It is also an excellent modality to judge the health of the spinal cord. Soft tissues are only best appreciated on an MRI. Spinal cord is a soft tissue. So health of the cord can be best judged on an MRI. Contrast MRI is also used to assess the healing response of anti-tubercular therapy, which I'll be discussing in my subsequent slides. Now look at this MRI, good looking MRI. This is the anterior disease showing the anterior collection. And look, this is a large posterior collection. This is a large posterior collection of a cold abscess. And these are the wedged vertebra, involved vertebra. Now, again, another MRI where on the sagittal cut, you see the anterior collection. The vertebra are all destroyed here. And now this abscess collection is going into the spinal canal, which will cause the neurological deficit, and it's going to compress the cord. Similarly, on a coronal cut, you see all the collection, which is all white. This is all the tubercular pus. And on the axial connection, this is the diseased vertebral body. And this all is a huge abscess. And you see this black structure, this is the aorta, which has been lifted away by the abscess. The aorta is actually being lifted away by this abscess. The black is the aorta, the great vessel lifted by this abscess. Next slide, please. Can we have the next slide? Now, CT scan has a limited role, and it shows the vertebral destruction, that is a bony destruction, earlier than the X-ray. It is useful if you're planning a CT guided biopsy. Now you have to get some image guidance while you're obtaining a tissue. So this is a typical CT picture of a vertebra of tuberculosis, where you see fragments of bone debris of the involved vertebra. And it is very useful in preoperative planning of surgery, that where do you have to put your implants and how much deformity you have to correct. Ultrasound it's a very good non-invasive diagnostic tool for delineation of deeper abscess in muscles, joints, cavities. It is also useful if you want to aspirate a cold abscess, which is deep-seated, say in the psoas region. So you can, under ultrasound, you can aspirate the abscess. And it also is useful in follow-up evaluation of psoas abscess, whether they are resolving under the influence of ATT. Otherwise, for seeing the bone and cord destruction, it has very limited role. It is mainly to assess your cold abscesses. Now coming to the PET scan, it is for diagnosing and differentiating multifocal lesions, where malignancy is also a differential diagnosis in an endemic region. Either you are dealing with a malignancy or a multifocal tuberculosis, which is involving many vertebra or many parts of the body. So there, the SUV max values can differentiate between infection and tumor. So a radiologist can tell you whether it's likely to be infective or neoplastic or tumor. And then the role of PET scan actually is in assessment of the healing response of anti-tubercular therapy when even your MRI doesn't give you a good picture. Generally, a FDG PET scan is done where the uptake of this FDG glucose in the disease area is an indicator of a persisting disease activity. So that tells you that the patient requires more ATT and you don't stop the ATT. That is the role of PET scan. Now coming to the duration of ATT, as per the standard guidelines, the duration of ATT does not change in patients of HIV. Now you have an intensive phase of 4 drugs. Then we give generally in our setup, we are giving a continuation phase of 10 to 16 months. In extrapulmonary tuberculosis, unlike pulmonary tuberculosis, you go in for an extended duration of anti-tubercular therapy of almost 1 year to 1.5 years. The current consensus is to give ATT on a daily basis, as per the government guidelines. Now, how do you monitor the treatment response? Now, clinically, you will see that the patient has weight gain or improvement in appetite. Hematologically, there will be a reduction in anemia, the hemoglobin will increase, and a decreasing trend in ESR. Now, decreasing trend in ESR in HIV may be quite misleading because the initial ESR may also not be high. Then we also monitor the LFT because your antiretroviral therapy and anti-tuberculosis therapy, both are potentially hepatotoxic, and you do get drug-induced hepatitis. Radiologically, what you see is the X-ray spine will show remineralization of the vertebral body. That means you'll get more white content on your X-ray. That means more calcium deposition. And you see sharpening of the disc margin, unlike the fuzziness of the disc margin. The healing of the disease may show bony or a fibrous union. That I showed you the previous X-ray where the 2 vertebrae had actually fused and it was looking like 1 vertebra. So you'll have a bony or a fibro-osseous union of the involved vertebra. So that is where you know that the disease is healing on a plain X-ray. MRI, we generally prefer a contrast MRI, which shows a resolving collection, reduction of the bone marrow edema, and replacement of marrow by fat, which is seen as a bright signal on both T1 and T2 weighted images. Generally, we don't get a MRI done before 9 months because the MRI response of healing generally lags behind the clinical improvement. So if you were to get your MRI very fast, you may be misled. So generally, we reserve our MRI to be done generally after 9 months to 1 year in our day-to-day clinical practice. Patients on ambulant anti-tubercular therapy should be instructed to immediately report back if signs of neurological deficit appear. That means if they have any weakness in the upper limbs or lower limbs, or they have difficulty in passing urine or feces, or they feel that they have difference of sensation, they should report back to a medical practitioner, because despite on ATT, you may still have a worsening of your symptoms. Sorry. Now, there is a paradoxical response also that in patients of osteoarticular tuberculosis on ATT who improve on therapy and then somehow they subsequently report with worsening in the absence of other diagnosis. First they improve and then they deteriorate. Now you may think that it is a drug resistance tuberculosis, but we have to prove that it is a drug resistance tuberculosis. There may be an increased size of the lesion, persistence of fever or night sweats, or development of another form of tuberculosis at another site also. If you are suspecting drug resistance, the patient continues to remain stationary or worsen on treatment from the beginning. However, in a paradoxical response, they improve and then deteriorate. So that is one clinical way of differentiating between a drug resistance and a paradoxical response. And in paradoxical response, all you do is continue your drug therapy and they improve in due course of time. The common causes of drug resistance in our setups in extrapulmonary tuberculosis are inappropriate treatment, that means the default, co-infection with HIV, where you can even have not the normal Mycobacterium tuberculosis, but atypical Mycobacterium, like Mycobacterium canceri, Mycobacterium avium. So a atypical Mycobacterium giving you a tuberculosis infection. Comorbidities like diabetes mellitus. This patient has both HIV and diabetes mellitus. Or the patient has exposure to a case with pulmonary multi-drug resistance tuberculosis or any other immune compromised state. The diagnosis of a drug-resistant tuberculosis is not, I suspect. It has to be a microbiological diagnosis. That means you have to prove it microbiologically. Drug resistance can only be proved on culture and sensitivity test. In spinal tuberculosis, the suspicion has to be clinical. You can suspect it clinically, which has to be proved microbiologically by a drug sensitivity test. You may have suspicion, but that you will not start a second line therapy in the absence of a microbiologically proved diagnosis. However, spinal tuberculosis is a paucibacillary disease. That means very few bacilli are there. So you may not be able to grow the bacilli and prove a drug resistance, which is a major challenge. It is very difficult at times to demonstrate drug resistance even after obtaining a tissue. Now, when will you suspect a drug resistance? In a patient on conservative treatment on anti-tubercular therapy who does not show improvement at around 5 months. Till 5 months, you have given ATT and still the patient is not improving. Clinically, there is a persistence of worsening of tenderness or fever. Hematologically, there may be a persistently raised ESR, which may be showing a rising trend. MRI may show a deteriorating lesion, or there may be an appearance of a new lesion. Or if the patient had ulcers and sinus, generally by 5-6 months on anti-tubercular therapy, these ulcers and sinuses heal. If the patient still has persistence, suspect a drug resistance. Or there's an appearance of a new cold abscess or new lymph nodes which have appeared. So suspect a drug resistance and start hunting microbiologically by obtaining a tissue. When will you operate a patient of tuberculosis of the sign? One is to establish a diagnosis and the other is to treat. So if you have a diagnostic dilemma, that means you are in doubt that, okay, the X-ray and the clinical picture are not very good. The patient may be having something else. Don't think that everything is tuberculosis. You may, after 6 months, it may be a malignancy, and by that time, it may be a full-blown one. So if you are in doubt, start the patient on ATT as a therapeutic trial. However, still that should not preclude you from obtaining a tissue. Send him to a center where a tissue can be obtained if you have a dilemma. Now, the pain is generally multifactorial, which could be because of the disease activity. Now you have some mechanical alignment changes in the spine, which will give you a mechanical back pain. Mild compression of the nerve roots in the chordae equina will give you a radicular pain to the thigh, which probably is the reason of pain in this particular patient, and then concomitant osteoporosis. So how do we deal with it? We can add a vitamin D supplementation and braces in the initial course of treatment. And once the patient is slightly better, we start them on physiotherapy with back and abdominal exercises. Duration is the same. Challenges that we face is a drug-drug interactions, shared side effects of medication, and TB iris as a paradoxical response comes in the differential diagnosis. However, all this data is largely extrapolated from pulmonary tuberculosis guidelines. Now, significant findings are the patient has been started on Oflox. Starting the patient on single drug is addition of a single drug generally is not recommended. We should at least start 2 drugs. So that is one area we can improve occasionally. If the patient is on steroid, now her HbA1c was 9.8. Those patients on steroid, they are candidates for a better glycemic control. That means you have to be more proactive in treating their diabetes also, especially patients on steroids. Braces may be considered in the early part of the treatment if resources permit, and regular liver function test monitoring. and keep a high index of clinical suspicion. Lastly, the clinical examination is very important. If you were to, tenderness must have been in the dorsolumbar region. Her X-ray was done for lumbosacral spine. Even her MRI was done for the lumbosacral spine. So wrong region was X-rayed and a wrong region was subjected to an MRI. Fortunately, in the periphery of the MRI, you could pick a lesion. We were fortunate. So index of clinical suspicion should be high and a clinical examination is important. Thank you.
Thank you very, very much, sir. This was really, really excellent talk. And I would actually begin discussion by the last point. I hope you realize what sir said, that actually we MRI'd the wrong side. The side that was to be MRI'd was the dorsolumbar spine, and instead the lumbosacral spine was actually imaged. And because I have seen so many prescriptions for X-rays, for MRIs, for CT scans, I think the first thing they do is it's just like a toffee or something that you give to everybody, an MRI of the lumbosacral spine. Jabki, as sir told you, the spine finishes at L1. Uske baad, we just have the nerves coming out from the rest of the bony vertebra. And if we are looking for a problem, we should actually identify that which part of the spine would be there. So it should have been dorsolumbar spine. And the other thing that I would like to summarize in this very, very briefly in the interest of time, there were so many important points, I really don't know what to pick up. We should have had a longer session for this. The case was long, then obviously the explanation was also long. Main thing that you need to understand is what is a cold abscess. If I would really bring out 2-3 points. See, a cold abscess is something which carries the caseous material, is a collection, but it is not at the site of the TB. It is what happens, the entire collection of debris, dead tissues, necrosis, lymphocytes, TB bacilli, they all track around the anatomical facial planes. They are already facial planes present in our body, leading from the spine to the periphery. So what you will see, you will probably see a swelling in the side of the back of the patient. Now this swelling is neither hot nor is it tender, but actually it is a TB abscess. It is a cold abscess in which the primary would be somewhere in the spine, and very trained people can also identify the approximate vertebra where it would be from by seeing the position of the cold abscess. I'm not giving that information because I do not expect anybody in the ART center to be doing that. But what I know we see very often is backache ho raha hai, backache ho raha hai, backache ho raha hai. So just slightly palpate the spine. One would be the tenderness. Second would be some swelling in the back. Sometimes there's a swelling in the nape of the neck. Sometimes there's a swelling around the spine, not on the spine, on the side of the spine. So if you have missed the 4S symptoms, that is of fever, weight loss, night sweats, if the patient does not have 4S symptoms, if the patient keeps on saying backache, keep a high index of suspicion of spinal TB. And out of all bone and joint TB, spinal TB is the most common. And among all spinal TB, thoracolumbar spine is most common. Look for cold abscesses, look for tenderness, and once you identify them, please appropriately investigate the patient. For investigation, obviously you will begin with the small things first. You will begin with a plain X-ray. If you can't pick up anything on a plain X-ray, don't stop. Please go on and get an MRI. Once you have an MRI which is indicative of something, I would suggest the staff of the ART center to refer the patient to a senior orthopedic surgeon who has the expertise to read these films and to take the next steps. The next steps would be to get a microbiological diagnosis. As Dr. Aditya already said, see, this is a paucibacillary disease. Pauci means isme less bacteria hote hain. Pauci means scanty bacteria hote hain. So in such cases, picking up MDR is very difficult. But having said that, that doesn't mean that it does not have MDR. So we need a mycobacteriological diagnosis for confirmation of TB and for investigation of drug resistance. So for these two things, you would need a sample. The sample would be best would be if you could tap a cold abscess, radiologically guided by ultrasound, by CT or MRI. And the other sample can be a biopsy from the vertebra, which very few centers would be able to do. A regular general hospital might or might not be able to do, but at least a radio-guided cold abscess aspiration might be possible in most general hospitals. Take a sample, it's a precious sample, you cannot tap it again and again, so send all the tests. By all the tests, we would mean that you send it for CBNAT, you send it for PCR, for LPA, for liquid culture, for smear for AFB. Do whatever test you want to do it at one go. Again, I would reiterate, do not miss the chance of getting an X-ray test done and doing a sputum microscopy, because sputum is the easiest sample. So if you have AFB isolated from sputum, either through microscopy or CBNAT or LPA or culture, and you have destruction of spine or changes in the spine, you can confidently say that it is TB, especially in a PLHIV, especially with diabetes. So do not overlook the value of sputum examination in a case of extrapulmonary TB. The other thing that we would like to talk about would be the duration of treatment. Can we have a thing from the index guideline? So what does, as Dr. Aditya very correctly said, the duration of treatment would be 12 to 18 months. I would like to project the index guidelines here. The index guidelines are the NTEEP guidelines for extrapulmonary TB. These are the ones for spinal TB. It says you give 2 RHE for 2 months and RHE for 10 months. All patients require close monitoring for development of progression of neurological deficits in the first 4 weeks of treatment. Duration, the total duration of ATT can be 12 months, but definitely extendable to 18 months on a case-by-case basis. So once again, for the ART center staff, I would request to always do management of such cases in consultation with an orthopedic surgeon. In such cases, the orthopedic surgeon for this TB has to be the main consultant, and we have to be the supporting doctor, and not the other way around, because it is the surgeon who will be able to diagnose, who will be able to collect a sample, and it will be a surgeon who will be able to decide on what duration of treatment is to be given, because they are able to use X-rays of the spine, MRI of the spine, and sometimes PET of the spine to find out whether there is sufficient improvement or not. So at 12 months, complete review of investigations would be warranted, based on which the orthopedic surgeon would decide whether it is to be extended for 18 months or not. So please always co-manage with the orthopedic surgeon, and let the orthopedic surgeon be the main consultant for this TB. And for the duration of ATT, you know what drugs to give, you know what doses to give according to weight, you know pyridoxine is to be given in PLHIV, you know once you finish ATT, you also have to give ATT for 6 months more, you have to give INH for 6 months more as secondary TB preventive therapy. All this is your job, but diagnosis पे confirmation लेना, duration पे confirmation लेना, ये सिर्फ आपके लिए orthopedic surgeon कर सकते हैं. Is this clear? I am not going slide by slide clarification, because that would take too much time, and I think the presentation itself was crystal clear. It doesn't need any summarization. It was absolutely clear. So, Deepthi, do you want to ask any question from sir? Have your problems been solved? Now you wanted to know why is there still pain, right? So as sir said, it is multifactorial. You want to talk to him about the pain, whether you could do something else? Deepthi, can you hear me?
Yes, ma'am.
Yeah. So you want to ask sir what more you can do for a pain? One, I thought what I can see is sir might advise a brace. He's saying braces should be given early. Second could be potentially surgery if it is an unstable spine. But please go ahead and ask your doubts from Dr. Aditya.
No doubts, ma'am.
It's clear?
Yes, ma'am.
And another thing that he said was about MDR TB, because as of now, we don't have any mycobacterial confirmation in this case. I would request you to send sputums.
Okay, ma'am.
Okay, keep sending sputums for CBNAT. If you keep on sending every sputum every 2, 3, 4 samples you will send, you might get an MTB. Number one, that would be confirmation of diagnosis. Number two, you would know whether you are dealing with R sensitive or R resistant. If you get a CBNAT positive, then also send for LPA. Okay. And for culture, you can send sputum for culture even without it being CBNAT positive. After some time, even CBNAT negative samples come out culture positive. Okay. So please send a culture. For pain management, get another orthopedic opinion. They would probably advise braces or surgery or repeat MRI or whatever is required, and keep an eye on the ATP. Yeah.
Okay, thank you.
So, sir, would you like to add anything before we?
My submission would be surgery may not be warranted at this stage. It basically, the patient should be on some calcium vitamin D preparation because she's obese,
Okay.
diabetic, postmenopausal age group. So treat her osteoporosis and exercises, alignment. So that would be, let's focus on these things also apart from ATT.
Okay, sir.
They go hand in hand.
So as sir said, I stand corrected. So first step is vitamin D and alignment exercises. Then probably you go on to other things like braces and surgery, which may or may not be required. But as again said, I am a medicine person. I am not the right person. So I think I also missed out on this important part, that how it should be scaled up. And thanks, sir, for telling us that. So at least start your vitamin D. Let them consult a physiotherapist now with the diagnosis of TB. I know earlier it didn't help, but now with the diagnosis of TB or spine alignment and a full orthopedic consultation. Okay. So thank you. So thank you very much. Thank you, Deepthi. And with this, we conclude the session and sign off. Thank you so much.
Thank you.
Thank you.